the second session. We will go straight to the action. And with me here is my good friend,
Hello.
Dr. Petros Odoulidis. So he has the task to start this session.
So we're going to proceed with the next case, which is a case done by Dr. Misrae, a case of GreenLEP. Are we ready to connect to the theater?
Can you hear me? Yeah,
Hello, can you hear us?
Yeah.
Hello, Dr. Misrae.
I hear you. But can you hear me?
Yes, we can.
Yeah. Okay. Good. Oh. Okay. There is a trouble. I need another fiber. The fiber is broken.
Dr. Misrae, can you please present the case?
Absolutely. Just a second, because I have a small issue with the fiber. You
Okay.
see the? Can you see the camera? The fiber is broke. The fiber is broken, and if I press the foot pedal to lasering, the laser will go out at this point and not at the end of the fiber, because the fiber is broke. So we need to change the fiber. So okay, stand by. Then you can remove the fiber. Put another one. Yeah. To screw. Yeah. Remove the card. Remove the card on the side. Now just put the new fiber. Now just before the fiber. Okay. Then you plug and then turn on the right side. Press and turn. Yeah, now the card, the new card. Good. I think it would be okay now. Yeah, it's okay. Okay, it's okay. Now with the new fiber, it's okay. So the case, can you hear me?
Yes, we can hear you. Now that you mentioned it, obviously, is this a single-use fiber?
What?
Is this a single-use fiber?
Absolutely, it's a disposable fiber. So this is the 2090 fiber. This is the HPS fiber, the old generation of fiber, 120 watt fiber that can be used to enucleate the prostate. To vaporize, we use the Moxie fiber, which is the most recent. When I say most recent, the Moxie fiber has been released in 12 years ago, so it's not really recent, but it is the most recent, the Moxie. And now we use the previous version, 120 watts, the HPS version, used initially to vaporize, and now we use it to enucleate. So for this patient, the patient has been in retention 2 times, and he has a prostate of 90 grams, refractory to medication. He was under Plavix, clopidogrel, stopped a week ago. So I guess we won't be in trouble with the impaired hemostasis. And we will proceed to an enucleation for this patient. So, are you ready? So the procedure always starts at the apex. The settings are 80 watts and 40 watts for coagulation. 80 watts vapor, it's okay. 40 watts for coagulation. So always start at the apex. So we see the sphincter here, and we immediately start the delimitation immediately after the sphincter. Can you see the video? Yeah?
Yes, we have a very good view of the video.
Okay.
Thank you.
Okay. So the point is to delimit the apical part of the prostate from the sphincter. Now we go gently. I use the coagulation mode, sometimes the vapor to do a deeper landmark according on how the technique has been described initially by Fernando. Like that. And the same maneuver on the opposite side. Okay, from the side to another of the verumontanum. Feel free to ask any questions you may would like to.
For the moment, we are just fascinated of how smooth and how sweet your motion is with the fiber.
Well, I can say it again, please. I cannot hear you clearly.
We are admiring your hands. You are very smooth.
Thank you. So you see the sphincter here, the landmark. I spent some time doing that. We don't want to rush the procedure, just because it's a live surgery, and then we are not in the same condition. I always remember when I started to do a workshop in my department, hosting some colleagues from everywhere, and I was thinking that, oh, okay, how good I am or how bad I am when I operate, when I have some people in the operating room, because we need to be aware of that. Okay, how are the results? And then I analyzed retrospectively the patient I operated during some workshops with some urologists in the operating room, and patients operated in normal conditions. And then I found nothing changed except the intraoperative time. So now the crucial point is to find the plane of dissection, blunt dissection. So I press a little bit laterally to the veru to find the plane, like that. Sounds to be the right plane, not too deep. Then I step back and I will detach the adenoma. I do some hemostasis, not to be overwhelmed, surrounded by small but significant bleedings, and I will detach progressively the adenoma, like that, really gently. Then I proceed to the coagulation, and again carry on my dissection of the apex. So I didn't find any difference in terms of postoperative outcomes for patient operating during workshops and compared to normal conditions. So I published this paper in open urology focus. But again, it's very important to know our own results to improve. It's a never-ending story of improvements, technical improvements, to keep the patient in good safety condition. So I continue my dissection. So vaporization is only 80 watts. We see the dissection plan here. And the side-firing fiber is not a problem at all to do this maneuver. So the fibrotic tissue here. So the point always is to determine where is the good plan. Am I too deep? Am I too superficial? So always constantly ask this question: am I in the good plan? Okay. So I continue to detach the adenoma. And I do some gentle movements to detach the adenoma here at the upper part. Okay, really gently, because sometimes the capsule is really thin. There is an anterior part, a significant anterior part. Okay. And again, carry on the hemostasis. Okay, so now there are some fluffy tissues here I want to get rid of. Okay. My limit is here. So I do this very gently. I don't put any traction, any force. Coagulation. I have some small nodules here, but maybe I will left that part for the end.
Vincent, it's Jean-Baptiste.
Okay.
We see that you are detaching the sphincter at the moment at the apex at the top.
Yeah.
And you told us yesterday that in your initial experience, you had 25% of incontinence after that kind of surgery. Now, you probably have passed your learning curve. Have you got an idea of your incontinence rates in the first months after surgery?
Less than 2%. Because initially I was not doing that maneuver. I was not. It was 8 years ago. Okay, so 8 years ago, I published that in the Journal of Urology in 2015. 2015, but it was the patient operated in between 2012 and 2014. And at this time, I wasn't doing early apical release. So that explained, and after now more than 1,000 of procedure, I constantly asked my clinical researcher to analyze the results of incontinence. The clinical researcher is calling the patient, collecting the data more accurately sometimes than me in consultation for some typical informations. So she's doing an amazing job, and this is completely, I don't have any regards on the data collection, because it could bias, of course, the results. If I say, okay, the patient is continent and he is not, okay, so he has some drops, some small drops that I should not consider as a real incontinence. Okay, it's biased. Okay, so now I continue to dissect the apex. Oh, fibrotic tissue. This kind of prostate is, I think, a little bit much more difficult to dissect than when there is no fibrotic tissue. Always check if I'm on the right plane, but I think yes. Okay, soon I will release completely the apex. Okay. I'm eager to find a much more easy plane for the dissection. But anyway, I don't rush. I'm not rushing. Okay. Sounds better at this point. Vision is clear. So the scope I use, the resector scope I use, is designed to allow blunt dissection with a smooth, very smooth tip and metallic tip, not in bakelite. Initially, I used the Storz instrument, but bakelite is too sharp too sharp to allow a blunt dissection. Okay, I think we are approaching progressively the bladder neck. But I need to dissect the upper part first. You see there is a nodules here that impair the So I progress very, very gently because the capsule seems very thin. Okay. I dissect progressively the posterior. Okay. Time to coagulate. Okay, it's very easy normally to do the hemostasis with the green light because the size of the spot is huge.
So
we can say that it's a quite different technique that we see previously because it's a lot of blunt dissection and hemostasis is section with the laser. Have you got some comments, Vincent, to tell us about this? There is a great difference in enucleation technique between direct and straight fiber laser, which is a dissection laser or combining with small blunt enucleation with thulium. And there, the technique that you show us, which is a technique with a lot of blunt enucleation. Have you got some comments about this?
I think both are efficient. Let's say at the very beginning, my incontinence rate was too much because of I didn't release the sphincter first, and when you do blunt dissection and you didn't release the sphincter, you put too much stretch on the sphincter when you dissect. But if you release the sphincter first, it's okay. But to answer your question, in fact, this is all a question of this is about how you make sure that you are in a good plan. If you cut and do the hemostasis at the same time with your laser, you have to make sure that you are in the right plan, especially at the beginning of your learning curve. Make sure of that, because you can create a plan which doesn't exist. And you will cut into the prostatic tissue in a plan that doesn't exist. So you have chance to lost in plans and to be much more deeper and to do a capsular perforation, which again is not a big deal. Making a capsular perforation is not a big deal. I was fearing about that initially, about the consequence, but honestly, the consequences are minimal if the perforation is small, of course. But I have to say that a different manipulation, of course, when I do 2-LEP. Okay, it's something to learn that you press the foot pedal every time, and you are in the right plane at the proper distance from the tissue. No. It's completely different.
It looks like a big part of the operation is being performed by feel, not by vision. Is this more difficult to teach to someone?
Sorry, say it again.
It looks like the biggest part of the operation is being performed by feel and not by vision. And I suppose that this is very difficult to teach to someone.
Yeah. Right. The prostate is supposed to be a 90 gram prostate, but maybe a little bit more. I would like to make sure that I'm in the correct plane at this stage. There are some calculus. And the prostate is really fibrotic. Okay. So far, so good, but
Can I ask you a question? We noticed that you're using like more than 50% of your, during the procedure, using blunt dissection, as Dr. Ross mentioned. Is this something that you started doing from the beginning, or this is something that you started to do after experience?
no, I started from the early beginning.
Okay.
When I start to work with the Wolf instruments, because with Storz it was really impossible to make a safe blunt dissection due to the bakelite, the different shape of the tip. I'm not sure. The prostate anatomy is really not as usual. I don't like this kind of. Yeah. Okay, so you see the blue. Now I'm supposed to be in the bladder, of course, yeah. Now I have the landmarks. It could be a little bit tricky to find the bladder neck sometimes, to make sure that you are in the good plane and not you won't emerge in the radius, of course. Never happened, but always clear about that. Okay. So we have the good landmark. What I found the most easy things to do with the fiber, the GreenLEP fiber, is the coagulation, because the tip is shaped to, the spot is shaped, the spot is really large, and then to coagulate, it's easier than when the spot is really thin. I think there is a small nodules here. Again, here, there are some nodules attached at the upper part of the prostate. Okay. So I will complete the liberation. Grab some water. Okay. There are some nodules here. Okay. So I continue to dissect even here at the lower part of the prostate. There are some fibrotic attachments. I'm not sure it's because I'm in good plan, I think, really. But there are some fibrotic tissue that make the dissection a little bit more complex. Sometimes we can think that, okay, I'm too deep or I'm too superficial, I'm in the adenoma, but no, here not. I will cut the cresta uretralis now. At the end. I slide in the plane. There is a median lobe, I think. You see the bladder neck here, and then we have a sort of median lobe, but initially I don't saw any median lobe. Okay, so the bladder neck, I cut the bladder neck. Okay, I will release the lateral attachment. Lateral attachment. So until now we have spent 34 kilojoules only, 34 kilojoules. No, it's okay. I was just saying that we spent some limited energy. Again, the nodules just behind, just underneath the bladder neck.
That's all? You hear me?
Yeah.
I saw that there are some attachment on at 6 o'clock, basically, just not far from the Vermontano. Did you left them by chance or by purpose? Just to avoid the lower rotate.
What do you mean? What I left what?
Yes, I saw that you cut at last some part of the adenoma were still connected to the Vermontano, basically at 6 o'clock. It was by chance or by purpose?
Yeah. Here?
You left them by purpose or by chance?
By purpose, by chance. I don't left the place for chance in surgery, but okay. This case, I have to admit, this case is not so easy, but I take my time. I will remove the nodule after. So far, no issues, no capsular perforation, nothing that I could fear for the outcomes. I will remove this fluffy things. Okay. Still this down. Okay. Attachment at the apex, but that sounds big to be good now. Okay. Seems to be okay. There are lots of nodules. Including this one, but I will left these nodules for later. Okay. I'm in a nice plan now. I constantly move. Oh, this nodule is not placed where I would like to. I have to be careful because the capsule is really thin with these kind of nodules. Okay, good. Okay. I can use the fiber like a small finger to find the good plane if I have a doubt. I always firing straight up to avoid injuries of the unilateral orifices. Okay, so the job is almost done. Still some attachment at 6 o'clock. Again, some attachments. I will check the euro after. So I peel the capsule. Oh. Okay. I can coag like that using I firing back from the area I would like to coagulate because the tip is eating the tissue and provide a good hemostasis in case of failure of the normal hemostasis mode, the pulse mode. So I will push gently the adenoma into the fossa. Now I will do the hemostasis. I want to keep the adenoma in the prostatic fossa to improve my irrigation flow and make sure that I see all the bleeders before proceeding to the morcellation. Again, another nodule. I always spend much more time for the hemostasis than initially, than when I started. A zone of frailty here, very thin. Okay. There is a small flap here. There is a small flap. I want to get rid of because this flap can impair the continence until it disappears. I remove again some small fluffy tissues with the vaporization. Okay, the edema is now flipped into the bladder. We will check the arterial orifices. Yeah, one. Where is the other? Yeah, here. The difficulty of this kind of prostate is that the aspect, the consistency, the fibrotic aspect of the prostate, and nodules, especially at the upper part of the prostate. Small flap. Okay. Sounds almost good. $60 kilojoules.
Can you please explain what means 16 kilojoules for some of us that have never used the green light?
60 kilojoules. Yeah, the fiber is limited to 400 kilojoules. 400. So we have. Unfortunately, we cannot reuse the fiber. Tons of nodules. Potential beach balls that we shouldn't left in the, of course, in the bladder. Okay, I think it's time to proceed to the morcellation. Okay. No, not yet. Okay. Fair enough. Mm-hmm. I would like to play snooker. No, I won't be able to. Okay. Give me the oscillator, please. The nephroscope. Could you raise the? Oh no. Okay, it's okay. The irrigation bags are enough higher. Of course, it's not the clopidogrel effect. That's fine. Okay. Okay. Nephroscope. Thank you. All right, it's okay. Can you help me to? Okay. Now we are ready to morcellate. Where is the foot pedal? Where is the foot pedal of the morcellator? Right side, please. Right side? Yeah. Vision is okay. I guess. No, I think there is a leakage because the bottle is filling much more faster. Can you speed down? Speed down, please. Speed down. Yeah. Here, you touch the screen. Speed down. Yeah. Il faut réduire la vitesse. Oui. Like that. Now you touch. Tu touches le. Oui, voilà ça. En fait, 2. Tu peux appuyer sur 2. Tu fais glisser. Voilà. Non.
Tu veux combien?
Je veux la moitié. Un peu moins.
C'est 750.
Je veux 500, ouais. Exact. Voilà. Allez. Ah non. Ouais. So there is a leakage somewhere. So can you give me this stuff? Yeah. There is a leakage somewhere. It's the problem with the morcellator. Sometimes.
So what speed do you use for your morcellator at the moment?
It depends. I have some leakage, some issues with leakage somewhere. I don't know where, but I noticed that the bottle is filling much faster than the collector of tissue. It looks like I have it's the morcellator sucks more water than he chew some adenoma. Okay, you see, if I press the foot pedal, there is nothing. Yeah, the adenoma, the morcellator is not grabbing the tissue. It means that I have a leakage somewhere. But I have some troubleshootings against that, like a small sparadrap on the handpiece. Fernando taught me so much troubleshooting for morcellation, for many other things, for lasers. So you cover the handpiece with a small drape, and then it's supposed to make things easier to limit the leakage of negative pressure of suction. You see the water, the bag, the water bag is the water collector is half full, which is not a good sign. It's not a good sign. It means that there is a suction problem. So the speed morcellation, I used to morcellate with 600 rotation. So on each side is 1,200 per minute. But when time comes to morcellate beach balls, so small nodules, it's better to decrease the rotation speed to the minimum. Well, it's better now. It's better. The efficacy is better. I wait a little bit for the bladder to be completely full. But usually, an adenoma of 100 grams, you don't need to change the water collector many times, just 2 times, or maybe only 1. But if you have to change your collector many times during the operation, it means that you should check that there is no leakage on the pipe connections.
Tu veux qu'on change le vocal?
There is no
On vide.
no suction anymore. Yeah, you should fill out. Can you decrease the speed a little bit? More? Yeah. 400. Again, yeah. I think there are some stones inside. Much more better.
So what is your rotation speed now at the moment?
I would like to reduce the speed for beach balls, but is it some stones? I think so. No? Yeah, it's a stone. Okay. I need another laser. Or, yeah, it's a stone.
Inside the prostate?
Yeah, no, not inside the prostate. I think hidden in the somewhere in the bladder. When I check the bladder first. I will do again. I will check the hemostasis. Okay. Maybe. Okay, we'll go back with the laser. Thank you. It's very difficult.
Oh.
No. No.
There is a Fernando technique for that.
Yeah. Oh, yeah. Good. Perfect. Sorry. Now, the irrigation. Perfect. I would like to see that I didn't forget to remove. Yeah, that's nodule. There is one. There is one nodule here. Yeah, this is a stone. And yeah, and a nodule. Okay. So it's a masterclass on stones. I never used Chromium for stones because I don't do stones. Exception made in the bladder. Yeah.
Ready?
Yeah, ready. So don't judge me.
So you're now using a holmium laser to break the stone, isn't it?
Yeah.
Okay. And that's an advantage of HOLIP, isn't it?
I have a retropulsion.
Βάλε το. Εγώ σου βάλε 700 κάτω και πάνω και 15. Ready?
Okay. Hmm.
500. Εγώ σου λέω 500.
Ouais.
500. 500.
Hmm.
Que je te fais un sous-set sur le...
Sur le bout du gant.
la queue.
Ouais. Tu me fais travailler en fait.
Non. Ça se passe sur... Il avait des liquides intraprostatiques.
Ouais. Faut appuyer.
C'est bon?
Sur la. Non, sur le laser GreenLEP pour pas qu'il s'éteigne. Parce que j'aimerais faire un tour d'hémostase encore. I would like to do a second round of hemostasis before proceeding to the the extraction, removal of the remaining nodules. Yeah, that's fine. Okay, that's fine. No need. Yeah.
Stand by for holding.
And green light. One more small round to complete the hemostasis, and now I will be able to emulsify
Vincent, one question, please.
Yeah.
Have you ever needed to go back with a loop for hemostasis instead of the laser?
I think why I'm going back for the hemostasis, that's the question. Because when the morcellator has a small leakage, in other words, when it sucks more water than it chews some adenoma, I noticed that all the hemostasis can be, all the vessels can reopening due to the suction effect. But it's not a big deal to patient first, and then
You're right, that makes sense, yes, increased pressure, suction pressure.
okay, nothing is bleeding behind the clothes. Have to pay attention on that. I noticed as well that, but again, no evidence for that, but I noticed that when the morcellation is long, there are some vacuum effect on the bladder, so some small bleedings everywhere in the bladder, like when you have a hemorrhage, vacuum hemorrhage, when you put a catheter in a patient and you remove faster the volume of urine, you will create a vacuum effect. It's the same with the morcellation. When it takes long time to morcellate. Okay, fine. So now I just have to remove the small nodules again. Don't know. Here. We need 4 hands. Yeah. It's always nice to be surrounded by gentle people. Like that. Ah. No. Ah. Ah. Ooh. Got it. Yeah. Perfect. Thanks for the hospitality in the dressing room.
Doing now. We are a little bit worried in the audience.
Okay. What?
Good morning. So show your both hands, please.
My hands?
Yeah, both. Because we hear someone moaning, we are pretty worried about that. You know, we are not exactly understanding what you're doing.
We were just trying to insert the.
Don't tell you anything to your wife, of course.
Where is the nodule? Oh, here. Where is the nodule? Nothing more. Okay. Irrigation zone. Okay. So No, it's okay. Some small bladder. It will. Okay. Are you agree? So now we can insert the Foley.
Είναι περίμενε λίγο.
No, I don't put.
No?
No. Only 20. Okay. That's fine.
Are there any questions from the audience? So we can conclude this operation with a big applause to you.
Thank you very much. It was tough.
Ouais.
Yeah. Tough. Because of the.
J'ai regardé un petit peu quand j'étais en haut, ça avait de très bons plans.
Ouais, de la fibrose. C'était. Pardon. You turn the mic off.
So have a little break for the next operation.